Okay, before we begin, reminders to all attendees of the 12th Biennial Symposium. You may type in your questions regarding the lecture in the chat box, and the speaker lecture can answer them in the chat box, or you may personally communicate with the speakers by sending them message to our email address. Kindly answer our evaluation form after the last speaker of the session. The link will be seen in the chat box. Now let's move on to our second lecture for this afternoon. And our second lecturer for this afternoon had her fellowship training in pulmonary and critical care medicine at Louisiana State University Health Sciences Center, USA, and a fellow with the Philippine College of Physicians and Philippine College of Chest Physicians. She's currently the section chief of the section of pulmonary and critical care in Philippine Heart Center and critical care clinical coordinator of the medical city. Ladies and gentlemen, let us all give a warm welcome to Dr. Aventura on her topic regarding lung focus, point of care ultrasound.
Good afternoon. I'm Emily Aventura, and I'm here to talk to you about lung point of care ultrasound. I have nothing to disclose. Today, I will highlight the basics of ultrasound. I will describe to you the fundamentals of lung ultrasound and outline the indications for thoracic ultrasound and demonstrate some of the more common findings. I'll describe to you the importance of lung artifacts in detecting the anatomy and pathology of lung disease. The technology of ultrasound imaging has been present since the 50s. But much like our cell phones, it has become more portable and hence more convenient. Thoracic ultrasound has rapidly gained popularity over the past 10 years. This is in part because of ultrasound equipment is available in many settings. More training programs are educating trainees in point-of-care ultrasound, and ultrasound can be done rapidly without exposure to radiation or contrast or the need to transport patients. A little bit of physics. Ultrasound energy is basically created by creating pulses of electrical energy by piezoelectric crystals. Inside the transducer is a piezoelectric crystal, and when you pulse it with electrical waves, it bounces in and out of tissues. By doing so, you create an image. Extremes of density from liquid, like air on one end and bone on the other, there's a lot of reflection and refraction. Most of the ultrasound energy bounces off, and you can hardly see through air or bone. So you try to look for liquid structures within the body so as to optimize the picture. So how do you optimize the picture? You have to choose the right probe with the right frequency, and you have to be familiar with the knobs on the ultrasound machine. There are several probes available out there, but what we use for lung ultrasound, there are three. There's the linear probe, the curvilinear probe, and the phase array probe. The differences in the three, there is a trade-off between transducer frequency and image quality and depth. The higher the frequency, the better image. However, the lower the depth. And the lower frequency, lower image quality, but you have better depth, meaning you can see deeper structures in the body. So the linear probe, also called the vascular probe, has the highest frequency among the three. However, it has the lower penetration. Hence, it's used mainly for superficial structures like blood vessels in the pleura. The curvilinear and the phased array probes have lower frequency, but they do have higher penetration. So you can see or evaluate deeper structures with these two probes. Difference between the two is that the curvilinear probe has a bigger footprint and the phased array probe has a smaller footprint. Both can be used to evaluate the lung and the pleura. This is an example of one of the ultrasound machine knobs and buttons. Don't be overwhelmed by this. All you have to be familiar with, at least for the basics of ultrasound, is the depth buttons to adjust and the gain. For the depth, you just need to make sure that your image is in the middle of the screen. Too shallow, you will lose information. And too deep, you might lose image quality though. As for the gain knob, over gain, you will have a wash out of the image. And under gain, your image will be dark. So you'll just have to adjust the gain as you see the visibility on the screen. On the transducer probe, you will see that there is this indicator or the orientation marker. This corresponds to the blue dot or sometimes the green dot on the screen. This just helps you orient yourself where your probe is on the patient and what you see on the screen. For orientation purpose and for uniformity, the indicator should be directed cephalad and to the right of the patient. This way, everyone will know the orientation of the image on the screen. So if one was to do a point-of-care ultrasound for dyspnea, for example, you will encompass several organs of the body because, as you know, dyspnea can be caused by cardiac failure. It can be from the lung, of course. It can be secondary to kidney disease, whether it's you'll see renal failure or hydronephrosis. And then there's the liver disease causing ascites and abdominal distension, and several other findings that potentially can cause shortness of breath. But for the purpose of my discussion today, I will only be concentrating on thoracic or lung ultrasound. So to be thorough, you'll have to be systematic. Some users divide the thorax into zones, the borders being the parasternal line, the anterior axillary line, and the posterior axillary line. How do you position yourself? Face the patient, as here, and then face the machine as well. And here, with this, you are basically looking at both at the same time. On one hand is the ultrasound probe, and on the other hand, you have to adjust the knobs for clarity of picture and depth of the image. You hold the transducer probe like a pencil, as shown here. And then to scan the thorax, you try to be systematic as well. You can use this method by scanning the lung. And make sure that you try to cover all zones so that you won't be missing any structures that are needed to be evaluated. If you find an area of interest, you can rotate your probe so as to fit between the rib space, as like this, so as to visualize underlying pleura and lung to avoid rib shadows and see a little bit more detail. So here, the Blue Protocol was created by Lichtenstein and Mézières and was published in Chess back in 2008. This was devised following an observational study of 260 consecutive patients admitted to the intensive care unit in France with respiratory failure. The researchers performed the Blue protocol without knowing any history or examination or lab results, and determined their suspected cause of respiratory failure, whether it be pulmonary edema, pulmonary embolism, pneumonia, COPD, pneumothorax. And this was then compared to the final diagnosis, often by CT as the gold standard. The overall diagnostic accuracy of lung ultrasound was 90%. It can look complicated, but it actually is not. But they also simplified it further. This is the simplified Blue protocol, wherein if there is consistently presence of lung slide, and if it's more of the A profile, meaning you see more of the A lines, which I expound later on, the diagnosis is more of COPD, asthma, possibly PE as well. But if you see more of B lines, then pulmonary edema is more of the diagnosis. And then if there's a combination of it, pneumonia is the primary diagnosis, pulmonary edema and COPD less likely. Thoracic ultrasound can be a spectrum from structures that are filled with air, which is normal lung, to all the way to fluid, as is seen here with pleural effusion. Air is, I guess, the greatest enemy of ultrasound. That's why we use gels as an interface to remove the air. But fortunately, even when you have healthy lung filled with air, artifacts are formed. And the interpretation of lung ultrasound is based on the interpretation of artifacts. Remember, air reflects, but it also forms reverberation artifacts or repetition of the pleural line. So it is repeated here, and it forms the rings or the ring down artifacts, or more commonly known as the A lines. So this is normal lung with ultrasound reverberating through air, forming the A lines. This in turn is the comet tail artifacts that we call B lines that we see in pulmonary edema. Again, the interpretation of lung ultrasound is based on interpretation of artifacts. Here is the ring down artifacts seen in normal lung, called the A lines. And here's the comet tail artifacts seen in pulmonary edema, called the B lines. So what you see here are the superior and the inferior ribs. And below them, you'll see acoustic shadows because ultrasound doesn't pass through bone or ribs. The thoracic wall here is skin, subcutaneous tissue, muscles, and fat. And the pleural line is composed of the parietal and the visceral pleura. This is sometimes called the bat sign, but I myself cannot imagine seeing a bat on this image. This slide will show you two things. First is the lung slide, which is the movement of the parietal and the visceral pleura against each other every time the patient breathes. This basically rules out pneumothorax, but only on the site at where you're scanning. Because on this other end is the absence of lung slide. Its absence, however, doesn't always mean the patient has a pneumothorax. Here, you'll see that the pleural line does not slide, and this might mean several things, like pleural fibrosis, or the patient's apneic, that's why there's no lung slide, or an actual pneumothorax. But you see here, there is a lung point, which is the border between the pneumothorax absence of lung slide, and the aerated lung, where you were seeing lung slide earlier. This other figure is the M mode, where you see the seashore sign, sandy beach seashore sign that corresponds to the area with the lung slide, hence negative for pneumothorax. On this other side is the stratosphere sign or the barcode sign, wherein you just see lines, which corresponds to the area where there was absent lung slide. This would be the lung point. And once you do see this, irregardless of knowing that the absence of lung slide does not always automatically rule in pneumothorax. However, if you do see the lung point, the demarcation between the lung slide and without the lung slide, this is pathognomonic of a pneumothorax. More representation of the seashore sign and the stratosphere or the barcode sign. Admittedly, it does sometimes take a little bit of imagination. Do remember though, on the M mode, so this is the M mode, the ultrasound traces a vertical line and this displays it in time. So only that line. So what you see here is actually this area here on the ultrasound. Again, lung point, seashore sign, the barcode sign or the stratosphere sign. Here you see pleural effusion, okay? The hypoechoic area is fluid. The hyperechoic structure is the diaphragm, and beneath it or below it, this is cephalad. So below it is the liver. This is the structure that you try to avoid during doing a thoracentesis. This is the lung that falls like a curtain sometimes. Here, on the other hand, instead of seeing just the simple hypoechoic area, you see septations or fibrin. This is what you see in the loculated pleural effusion. Again, this is diaphragm, liver, and this is fluid. The lung should be here if it were to show itself. And this is the ultrasound finding of lung consolidation. As you see here, the lung has almost the same configuration as the liver, hence the term hepatization. And here are some more examples and findings. The first figure here, you see the pleural line and then B lines going down, obliterating the A lines, which are supposedly horizontally oriented. And then in this second figure, the B lines are thinner, which would correspond more to ground glass findings there on CT. So thinner B lines, more of ground glass pulmonary edema as well. In this third structure, you'll see the lines without significant lung slide, the irregular pleural line without significant lung slide. This is thought to be secondary to inflamed tissue seen in pneumonia. And then this fourth figure or video, you'll see confluent B lines seen in pulmonary edema. So again, B lines, pleural line with B lines seen in pulmonary edema. This is also confluent B line seen in pulmonary edema. There's some irregularity in the pleural line here, which signifies some form of inflammation, likely secondary to infection. Okay. More images. Here you see the first image, you will see a discontinuation of the pleural line. There's like a notch there. It's called the shredded lung line, representing inflammation as well, seen in infection, inflammation. This second figure, as you can see, it's irregular subpleural consolidation. This may be what you may see in their COVID patients because findings of infiltrates and consolidation in our COVID patients is usually subpleural. The third is again a shredded lung line, again signifies infection, inflammation. The fourth figure again is inflamed tissue. So you see here. And this fifth figure is translobar consolidation with a very prominent air bronchogram. And almost the image of the liver, almost same configuration as the liver, hence it's called hepatization. And this last figure on the right lower corner is the lung that's consolidated as well, but around it you see fluid, much like the one I showed you earlier. So I can't end my talk without discussing a little about COVID. This is a study from the Chinese Critical Care Ultrasound Study Group that compiled the CT and ultrasonographic features of COVID-19 pneumonia. And it does not seem to be too different from what we see in ARDS or other pneumonias. So these images will be the same as what I've shown you earlier. The exception is that pleural effusion is relatively rare in COVID pneumonia. And I would like to also emphasize that, especially now in COVID time, make sure that you maintain sterility or at least cleanliness of the ultrasound machine. Prior to going in the room, make sure that there's no clutter. A lot of times there's a box of gloves or the bottle of hand gel. So make sure even those are cleaned and wiped down. After using the ultrasound, make sure there's no visible soil or blood in the ultrasound machine, and wipe it down to include the cords, the keyboards, and everything are in it. Sometimes we even do SanoSeal, right? And then do follow the wet times of the manufacturer and the cleaning materials. And after exiting the room, another wipe down to ensure that the device is cleaned properly. You can look up on the EPA website on what cleaning ingredients or cleaning material is recommended per machine and the wet times that's recommended, like how many minutes. I'll end with this. So the technical part of lung ultrasound is not difficult when you start doing it. But like any skill, it takes practice to improve on it. Thank you and stay safe, everyone.
Thank you, Dr. Emily Tan Aventura, for that very wonderful lecture. And in behalf of the Philippine Foundation for Lung Health Research and Development Incorporated, in cooperation with the Philippine Heart Center, Division of Pulmonary and Critical Care Medicine, and with deep appreciation for your presentation, we would like to award the certificate of appreciation that reads the 12th Biennial Symposium, Exploring the New Novel Explicable Wonders in Pulmonology, given the 16th of September 2021 at Quezon City, Philippines, and signed by our chair of the Scientific Committee, Dr. Maria Paz Mateo, our overall chair, Dr. Bernice Ong de la Cruz, our chair of Scientific Committee, John R. Jimenez, the head of the Division of Pulmonary and Critical Care Medicine, Dr. Irene D. Guzman. So on. And of course, the current president of our foundation, Dr. Cesar Antonio. And we would like to invite all the participants to attend the Boehringer Ingelheim Dinner Symposium after the last session.